It's a question to Rich. So what explains the additive effect of the core and the nukes that you showed?
I'm sorry, what is it?
There's an additive effect of combining the cores?
No, there's actually a synergistic effect.
Or even, but what's the mechanism? How does that work?
Well, all right, how does it work? You're stopping basically 3 steps. So cccDNA is generating core protein, which has to encapsulate the pgRNA, right? We stop that, right? If anything gets through, then clearly the nuke is going to stop the transcription or the copying of that RNA in the double-stranded DNA, right? The virus can't get out. Any virus that breaks through, then the core inhibitor is going to melt the capsid going in, and so you will not be able to get more cccDNA generating, which is really a key here. And a very important point of all this is in the concept, because it's a very unique thing with cccDNA, compliance is going to be critical, and this is why we've tried to optimize these compounds the best that we can, one simple, 1 pill a day, co-formulated drug, because if you miss a dose with hepatitis B, unlike hepatitis C or other viruses, all right, the virus gets to replicate another day, and you try to catch up, but here's one other thing.
Sure.
But if you allow the virus to generate more cccDNA, you've got like a 3-month window, you've got to get rid of it.
So if you would be able to increase the efficacy of the core inhibitors, would you be able to get rid of the nukes? Is that what you're saying?
Yes. It's really trying to get in patients, because patients have variable, of course, like most patients are, is to get the multiple of the concentration that you need to truly shut down everything by at least 10 or 50-fold, okay?
Sure.
So we're trying to get that kind of concentration, safe systemic exposure, and have that blanket basically on for 24 hours.
And is there a potential to make them long-acting, the compounds, to make a long-acting formulation for them?
Long-acting.
Like that you don't have to do it every...
compound. Ask him if he wants a long-acting compound.
Let's first get this done, and then we can go to long-acting,
so.
right? Let's.
So you do have a compliant system, and that's the animal models. I'd like to know what your experience, Jason and Richard, have been with animal models, and if they predicted what you saw in the clinic. Because we're going to spend a lot of time at ASLD talking about animal models, so I just want to know what your thoughts are, and if they were useful for what you were doing, what you were doing in terms of predicting, and they are compliant, assuming you dose them every day.
Well, we have not done any animal studies.
So you went straight into humans?
No, because look, I spent 3 years doing a woodchuck study, and I cured woodchucks with entecavir, right? It's predictive of nothing. Okay, no, I'm just saying. So the animal models don't really mimic. They were always designed as antiviral models, okay? We're talking about chronic infection trying to replicate the human system, right? And there is no animal model to really do that, okay?
Well,
chimps probably come the closest.
Your opinion may be different from other people who work in animals. I don't do animals, but I just wanted to know. What's about you,
And we are the
Jason?
same. All the preclinical experiments we did were all primarily in primary human hepatocytes.
Yeah. And Rich, just another question quickly, and that is, you seem to ignore completely the integrated DNA. So tell me what your thoughts are.
No, the thoughts were, as I answered earlier, I think during that period of a year or so, if you shut everything down, right, those cells that had integrated DNA will die off also. Okay, that's it. Right. But even if they didn't, okay, the integrated DNA is not going to actually cause much disease, right? It can't reinfect, right? You'll be able to come off a drug. You may have a scar for life if cells lasted that long to say, yes, at one time you were infected with hepatitis B. But as long as we believe, which I think we do, that you're not going to get active replication off of integrated DNA, it shouldn't actually matter.
Stefan Irvine, can you make one comment about?
I just would like to comment, you were so nice, Jason, to show and implement the pre-S inhibitor Mercludex in your cccDNA formation assay. And you use 500 nanomolar, which is much more than the IC50. So I just wanted to make the most potent way to inhibit cccDNA formation is using Mercludex at the moment, if you compare that with your with your capsid inhibitor. I mean, your 340 nanomolar is more than 1,000-fold more than you need with Mercludex. So I just wanted to bring that again back into that we have, if we do not have a replenishment going on all the time, no advantage of a capsid inhibitor towards preventing cccDNA formation in comparison to an entry inhibitor.
Yeah, you make it.
So it may be synergistic, I don't know, maybe one should think about that, but we should keep that in mind. Yeah? I mean, you were so nice to show that. Yeah? And of course, we know that entecavir and all these nucleoside analogs do not interfere at all with cccDNA formation, and that's the major drawback. I completely agree that the synergism of a capsid inhibitor with a nuke is very interesting to see what's happening in patients. But in my view, you end up with an entry inhibitor monotherapy in the efficacy with that combination.
Would it drive down the duration? Because the duration of the treatment is a big unknown. What is the half-life of our liver, basically? Because you wouldn't need any immune modulatory therapy, just with these two antivirals that would do the job. In your case, how long would you have to treat to get rid of Delta? Or HBV?
No, I'm talking about HBV. I'm not talking
about
Delta.
HBV. What is your assessment?
I mean,
is it a year? Is it 2 years? Is it half a year?
What we see in our entry inhibitor study, which is not published yet, on HBV mono infection is a reduction of about 1.7 log in 24 weeks. If you take it serious as a marker for cccDNA reduction, because the entry inhibitor cannot do anything more than reducing the cells. And then I have not calculated that, but this would be years, and we would need to do a synergism. And I personally think that the synergism is immune stimulation of the endogenous immune response by any kind of drug, maybe interferon or maybe any drug. So to get also rid of S from the integrate and not only cccDNA. If we would eliminate cccDNA in a Delta patient, I would predict that nothing happens. He will replicate Delta further on the basis of the S antigen that has been integrated, and the pathology is thing. Absolutely.
So can I ask the CAM inhibitor people, actually, how does these CAM molecules inhibit de novo cccDNA? So as the virus is coming in and uncoding, which do the CAM inhibitor molecules bind to the capsid and lock disassembly?
I think
Have you shown that?
I was just listening to. Our view is that it probably locks the capsid structure and prevents the disassembly, and therefore the release of the redact circular DNA into the nucleus, and that prevents the formation of the cccDNA. I think you might.
No. We actually show that you melt it. Okay, we have capsids that, again, you treat with entecavir, you treat with a core inhibitor. 3 hours after infection, you look what's going on. You find that entecavir, 100%, you can see the DNA in a capsid. With the core inhibitors, there's nothing there. It's empty. So ours is a little bit different. We think it melts it, actually. We think it's a melting that goes on.
Okay, the people in the immunology corner get a bit nervous because they want, Adam wants to make a comment, I think, right?
That's right. No, and I kind of have a question because with the RNAi, the CPAMs, the NAPs, they're all changing the distribution of HBV antigens within the infected hepatocytes. Has anybody looked to see how that affects recognition of these cells by T cells, or does it upregulate death receptors that might make them visible to NK cells? Something's got to be explaining some of the ALT increase. It'd be nice to know what that is.
I'll say we're working on it. We want to know what's going on with those flares, and there's going to be a very in-depth immunological analysis of what happens in the phase 2A trial with the ACTG. We're going to look at everything to try to get an answer as to what's going on in those patients. Absolutely. I think that from my perspective, when we look at what we're doing with NAPs, just clearing the way for the thing which is going to be most effective, which is restoring the immune response. This is what happens in 80% of patients, right? They have immune control. They're acute resolving patients, and that seems to work pretty well. And I think that's sort of the paradigm for what we're doing. So we want to understand as maybe a helpful guide to the immunologists about what is going on with those flares and that anti-HBs production, because we see pretty high rates of control of the virus persisting after we remove treatment.
If I may touch upon that, I think you have to be very careful with the term asymptomatic flare, because you've had very few patients that have been treated, and a few flares which were actually very high that they were not visible at the top of your panel. And I mean, you cannot say an asymptomatic flare, because they typically are asymptomatic until the patient develops liver failure and dies or needs a liver transplant. So I think you have to be very careful with that. If you're unlucky, then the patient might do very bad, actually. So I think that's important to stress.
Yeah, I agree with the cautionary tale completely. We've treated 77 patients to date. 80% of those have had a liver flare, 75% of them have been very strong. When I say asymptomatic, it means, we do high-resolution sampling of those patients every week for LFTs, and there's no changes in bilirubin, albumin, INR. Patients have no jaundice. Patients feel great. And these are all happening in the context of reduction of viremia in those patients. So it is a cautionary tale, but we do have pretty good experience, I would say more than most, because a very high proportion of our patients do have these flares. And in all cases, they have been very well tolerated with no evidence of decompensation at all throughout the whole treatment and into the follow-up.
Yeah, let me just say that we didn't design the 2001 study or this 1001 study with ARO-HBV to have biopsies. It's my belief, that we're entering an era now where we're going to see, unlike the problem that we had with nukes, where even interferon, where these things were so the few patients that actually cleared, did it in such a variable time course and at such a low frequency that very hard to design a study and feel like you could catch something. I feel like we're now entering a different era where we're going to start to have some combinations or compounds that are going to give us more predictable sorts of responses, where biopsying becomes more feasible, becomes more reasonable, and you have a better chance of maybe catching what's going on. I mean, we biopsied the chimps very frequently, and we also sampled them very frequently. And you may remember a few years ago at HepDart, we showed data where you could see gamma interferon, moving. You could see CXCL9 and 10 moving, and you could even see in some of the chimps, you could even see ALT moving, sort of in tandem with those. And then we have biopsies, at the same time, and have seen some gene pathway changes that occurred in some of the monkeys as well, and in some of the chimps as well. Very hard to do that in humans, but I think, like I say, we're getting to the point now where it will make sense, and you could do a small enough study because the intent, the percentage of patients that are actually going to show you something will be high enough that you don't have to biopsy 100 patients. Maybe you can biopsy 10 or 20 and actually learn something. So I think your frustration is justifiable, but I think it's largely just been because you haven't had any tools that were actually helpful, that people could do a practical study.
I agree to some extent, but these are simple in vitro experiments that can be done as well to at least start to understand, because some of your injection of these siRNA, you might get very acute reduction of some of this antigen presentation within hepatocytes that makes them invisible, and then you had this rebound very rapidly that could cause that ALT flare, but that won't actually be picked up in your S antigen sampling because your windows are too wide. And so you'd almost be like a stop study, essentially, where the antigen goes away and then bounces back really fast, and that creates this ALT elevation. And I'm just trying to understand, how low do you have to low? How low do you knock down the antigen? Or for the core inhibitors or the CPAMs, you're degrading extra antigen within hepatocytes. Now, are they becoming more visible to T cells? Just to start to understand the basic mechanisms of recognition, not necessarily like biopsy level resolution in clinical trials, because I realize the challenge of this, but it comes back to the immune response with these drugs that are available now. We really start to have ability to start to explain some of these, I think, with really starting to understand the basic immunological mechanisms of target cell recognition.
Well, I think you and Mala have sort of convinced me that it's what's going on in the liver that's important, much more than what's going on in the periphery. So I think I think to answer some of these questions, we've got to know, no kidding, what's going on in the liver, personally.
Short comment?
Yeah, go ahead.
Just a short comment to that question. You can test it easily in transgenic mice, for example, because the capsid inhibitor would work in transgenic mice. You reduce it, then you restore the antigen presentation, for example. So there are animal models where you can check that very nicely, I could imagine, the secondary effects that the direct antiviral would have on the immune system.
If you think transgenic mice are going to predict humans.
Okay, so
that's
we
another question, of
have
course, but at least you can check whether.
Thomas and then Massimo.
Andrew, I have a question to you. And I think it's in a way intriguing that you have shown that there's a correlation with undetectable S levels that is followed by this ALT flares. Is it correct? So you observe these flares when S is already disappearing or disappeared from serum?
There are two kinds of flares. There are flares that come at the start of that S drop in those patients that will go to 1 IU, and there are flares that wait until the S is far down. And in fact, there's a lot of interesting data that I didn't have time to show about flare geometry and dynamics with those different patient populations. So I think one of the challenges here is, and I think it points to the comment that Adam was making, which is it's very hard and probably important to get a handle on the immunological status of patients. You know, like what happens in interferon to those magic patients that have an EVR? Is there something special about those patients than the other patients that just go along with small reductions in viremia? So we have some additional data, which I just don't have time to show, but there are some differences in the magnitude of those flares when they happen. Those patients all tend to, again, have control of the virus, though, off treatment.
Yeah. So could it be as an hypothesis that you create a situation within the hepatocyte of infected hepatocytes that will lead at the end to cell death? I don't know, because of retention of whatever. But then in the same way you have prevented uninfected cells from becoming infected, because I think the results are incredible. Such a high rate of S.
I don't think, you know, for me, I look at Miraculix B as the gold standard for this, shielding the liver. So I don't think what we're doing here is providing a permanent shield of the liver. I think what we're doing here is what aspect of the immune system is being restored, I can't comment on directly, but I think what we're doing here is by getting the surface low enough during treatment and providing an immunotherapy, we're restoring that immunological control. So I think there's cccDNA and a lot of those hepatocytes, just like in patients that have acute resolving hepatitis B, it's just now under stable control.
Okay, Massimo?
I will go back a little bit to virology and the capsid inhibitors. I got not confused. Let's say I see that there is a room for divergence in the interpretation of the same data, because somehow Stefan is telling us that Mirclodex to obtain the effect on capsid on cccDNA for the capsid inhibitors, you have to go higher in the dosage as compared to the antiviral effect. And that was somehow reflected in the first generation data presented from Janssen. Richard, you went on saying the more potent is the capsid inhibitor, more you level the two, and you have not so much of this difference. But at this point, there is another big issue that is a kind of elephant in the room that we don't mention, is what is more important. I mean, we discussed it a lot, but it comes again. What is more important? The incoming new virus to reestablish cccDNA, that is one supported by a lot of data, or the recycling that is again a la mode because of the latest data published very recently also from Ulla Protzer. So I think that until we do not really are able to measure these two components, we will not understand. Finally, if it works, when you use it, very potent, and you get the results, you are not very interested in how it works. But if you want to do science, I think it's very, very important to dissect the two elements, that is recycling and incoming capsids. And we may even have a situation in which different compounds, just for the chemistry, are more apt to target something that is coming from a different pathway to the nuclear pores, or something that, because we don't know the recycling, how it goes, and we have some data for the incoming virus, how it goes to the nuclear pores. So I think there is a big issue there. I know that I'm kind of putting oil on the fire, because Stefan will come back, and I know that, but it's good. But I really would like to know what you think from the capsid inhibitor perspective. if you have a very potent one, you level the effect. You have data for that. You really are able to show this. If you have a system in which you have only recycling, can you block it at different levels?
That's a great question, and actually we do have some compounds that do a lot of different things, right? They're different, that's why different chemical platforms, different things. We do have compounds that actually all they have is antiviral activity. They don't actually touch, they don't melt, okay? They don't prevent the cccDNA flow. We don't have the other compound that you want, okay, which is the one that melts and doesn't stop the encapsulation. But these compounds do have these different ratios of activities, and some are devoid of one activity anyway. But what do we want? At the end of the day, I have a kitchen sink approach. I want all the activities, right? Because the more activities I can get, the better the chance we're going to succeed in what we're trying to do. But, interesting point. But we do have different compounds that have different profiles. It's actually was surprising to me that we would keep the same.
Differentiate from incoming virus and recycling?
Yeah.
Yeah.
That's very important.
Yeah.
Just one point, 3 hours after infection, cccDNA is already started. Because you can even ship cccDNA after 2 hours. So I really would modulate very well the modeling of the different effects.
I would like also to comment on that because it's really a very interesting question. I mean, we have now this evidence that extracellular virus is doing a lot of job. And no question about that the capsid re-import is a salvage pathway for cccDNA. It's not meant to all the time circle up because you don't want to go into error catastrophe, but the cell want to have a kind of salvage pathway to do that. And therefore, I guess the best entry inhibitor would be a really good capsid inhibitor because you are just a step further. Yeah. My concern is that since we know, for example, a core minus virus, a capsid virus that doesn't encode a capsid, and you showed this data also where you put the capsid inhibitors after establishment of cccDNA in vitro assay, you need weeks to maybe see an effect. At the moment, we don't see an effect. I guess you see the same in patients. If you go for this additional effect of the cccDNA replenishment inhibition, you may have to do clinical trials where you compare, for example, Merclodex monotherapy for the exogenous versus the nuke therapy for probably a year or half a year until you see a difference. This is a very important point. Yeah. So we talked about missing maybe an important mechanism by the shortening of a drug trial.
Okay, Gaston, and after that, Simon. Yeah.
Yeah, thank you. So I wanted to ask the panel if what's the current understanding of half-life of infected hepatocytes? Because to your point, Rich, I mean, if I buy that concept, we need to, you will have to go for, let's say, start with a year and you'll see whether, assuming everything is completely shut down, there's no reinfection of hepatocytes, it will take whatever time the half-life of infected hepatocytes is to start seeing a decline in HBsAg, and so maybe you have to wait 2 years. So the goal, I expect, is to do that as soon as possible. So perhaps some other interventions will help accelerate that process rather than waiting.
Right.
I agree with you that if you have pharmacologically favored compounds, more potent compounds, you can probably close the window. But the question I still do not have an answer for after I don't know how many years of hepatitis B history is in a chronic infection, what's the contribution of new rounds of infection versus infected hepatocytes pumping out surface antigens to establish a set point of HBsAg antigen a chronically infected patient has. So if I shut down one thing, I still see HBsAg going on for how long, which is going to be driven by the half-life, I presume, of infected hepatocytes. I also agree that infected hepatocytes that have integrated HBsAg are not going to do anything at all because eventually they're going to die off or they're going to be cleared by a reinvigorated immune system at a certain point. So I'm not so concerned about that, but I still do not know what's the working hypothesis in terms of how long do we have to treat based on viral dynamics?
Sure. Well, first, it's just one general thing, I think, for everybody, and it's very important for the field. I think probably the biggest hesitation now to treating patients, which they should all be treated, quite frankly, with the nukes in the meantime, is this you're on for life, okay, kind of concept, versus just coming up with what they find. Even if that's 2 or 3 years, I don't think it actually matters. As long as patients knew, if treaters knew, Put you on, 3 years later, you have whatever percent, a very high percentage of being cured. I think that's a success. So our initial studies are really just to show the concept. If you show these things are going down, then it's a matter of the trajectory of that, right? And it may traject out to 2 years, it may be 6 months, or maybe 9 months. But the first victory is, do we have a mechanism, a way, a strategy to actually finally start to deplete cccDNA, right? Which we've never been able to do before, right? So this is the concept, I think, for all of us. We just need to get to that next stage, right? And then we'll figure out how to do it better. And the better may be combining a bunch of things together that, to get the best of all worlds. And the beautiful part now about the field, where we've come from, and a couple of years ago, a lot of concepts, right, early compounds, we now all have clinical databases, right? And once all these various agents have safety, then you're safe to put them together, actually, and start to do some very early combinations to try to tease this out. But the first thing is to show we're going in the right direction.
So what's the half-life of
Yeah, but may
I already asked that question, basically. So
yes, but I would like to answer your question, because if you would agree that an entry inhibitor prevents newly formed hepatocytes, then the virological response that you measure in the liver that you obtain by an entry inhibitor gives you an answer to that question. If we do that for delta, we come up with 1 to 2 weeks of a delta-infected hepatocytes, which is much shorter, although we have spread, as I showed you. Yeah? So that I interpret it as a way that delta is cytopathic to some extent, yeah? Which makes an entry inhibitor an advantage. Now the question is, we would like to know that for HBV, if you take a DNA decline with an entry inhibitor as a readout for for cccDNA, then you end up with 2 or 3 weeks. So it's quite faster than you have for unhealthy hepatocytes. The question is that you normally don't accept a DNA in the serum as a marker for cccDNA. We have to measure maybe RNA decline, yeah? But of course we learned that S antigen decline is not reflecting the cccDNA, which we initially thought that it may be in an E antigen positive patient, maybe, but in an E antigen negative patient, not at all.
Stefan, is that in patients who have an elevated ALT? I don't know the details of your trial. I mean, what about a patient that's got an ALT
that's
of 20?
Of course, that's a very important point that you add in addition. This is probably very specific for patients. I showed you the decline of the different, in the delta patients, which is individually different, yeah? And it's also interesting in the delta, it's different from the genotype, because maybe a genotype 3 is much more cytopathic than a genotype 2, as we know, and you may have the same thing also in the B. But what I would say from these results is that it's much more pronounced than we think, so it's a much shorter half-life time that we have for a normal hepatocytes with a normal ALT level, which we think is 120 days. I don't know exactly, hepatologists know better. But we go shorter, so we go in the week range, and I think the calculation that you at the beginning made, yeah, should not be done
35 years.
Yeah, that the S antigen decline that we measure gives us a kind of good measure on that.
Okay, I understand.
On that.
Okay, the very last question is for Simon Fletcher.
Sorry, I was going to ask Rich a question, but he appears to have run off. But, I'll ask Jason instead. Yeah, so I mean, it's good to see the differentiation of CPAMs, CAMs, whatever we're going to call them, against nukes in vitro. We get maybe greater decline, but I still struggle why they still seem to have the same biphasic response clinically. I know they're quite slow, it's early days, we still have a quite rapid first phase, and then seemingly we're leveling out in the second phase exactly the same as nukes. So I was wondering if anyone has a good explanation for why that would be the case.
Good question. I don't think we have an explanation just yet. We are still in the early days of trying to understand capsid assembly modulators. Hopefully once we generate more clinical data, we'll have a better sense of what the different doses do in the different patient populations.
Okay.
I mean, I think it's been strange, that this synergistic effect with the RNAis and the nukes, is all over within a few days or a couple weeks, and then you get that more normal slope. But the initial effect over the first few days is multi-log just slams it down, and then it goes into that more normal decay.
So I'd like to close the meeting. We had a phenomenal amount of very interesting and good lectures, and I really want to thank all the speakers in the first place for giving us such a great meeting with a lot of discussion. I'd like to thank all the people who attended this meeting. I'd like to thank the sponsors. I'd like to thank the team of Charles Boucher, Virology Education, for organizing this meeting, and we'll hold it again next year in Toronto.